My apologies for the greater than 1 year gap since my last episode. It's been quite the year moving my work back to full-time in Vancouver and providing patient care in our new normal of a pandemic. There are many more episodes that have been recorded. I'll keep trying to get them posted more often. Email me at podcast@iguy.org if you would like to be on a future show. In this episode, I talked with Juan Kim, a glaucoma colleague based at Walter Reed National Military Medical Center and Hospital in Bethesda, Maryland, about why he has been combining multiple minimally invasive glaucoma procedures in patients who have failed traditional glaucoma surgery. I'm Rob Schertzer, a Vancouver, Canada-based glaucoma specialist, podcaster, and HealthIT expert, and we're talking about glaucoma. Juan Kim, welcome to the show.
Thank you, sir. Thank you for having me.
So you have sort of a unique approach. I don't know if this is what you do with every patient, but we always hear about having some sort of staged approach, or starting with laser and MIGS and then another MIGS. And we've heard of combined glaucoma procedures in the past, like combining a tube with a trab. So wait for the tube to evolve and have the trab kicking in at first. But you've been able to do these cases where you do multiple glaucoma procedures on the same patient. So tell me, how come, why?
Yeah.
Should other people be doing this?
Yeah, I think it started initially with trying to minimize complications, number one, and understanding that MIGS has a little bit less efficacy than our traditional surgeries, and that's without question.
Right.
So I would come across people that I felt like were high risk for complications, and I had some experience with MIGS at the time when I started doing this. It was like 2013-ish or so, I can think of one gentleman who was a retired general. His fields were progressing. He had severe field loss. His superior hemifield was essentially all gone, and it was clearly progressing, and his pressures were high teens to low 20s, probably averaging around 20 or so. And he'd been vitrectomized. He's formerly a high myope before his phaco, and so he had some risk factors for maybe having some complications, with traditional filtration surgery. So he's educated, smart man. He wanted to know his options. So I just sort of gave him my full toolbox, at least what I had at the time. So I had this thing called trabectome. Right. It doesn't typically get pressures in the low teens. That's kind of what we'd like to shoot for you because of your advanced field loss. And I have this other tool called ECP. It works a little bit differently, but maybe the two could complement each other. And they both would have a very minimal risk for hypotony-related complications, which would be what I'd be a little bit afraid of for you.
Could be catastrophic.
And I think he'd also had if I remember correctly, a scleral buckle. So maybe a trab was maybe not such a great idea in his eye. We could have done a Barvelt, easily. So we just floated the idea, and over multiple visits, we decided, well, why don't we just combine this and see if we get what we want. And so we did it. I did trabectome and ECP, and that was probably one of the first combinations that I tried. And lo and behold, he got some really low pressures. He was also allergic to Alphagan. He was on sort of maximum medical therapy at the time for him, which was sort of Xalatan and Cosop. Okay. And it was like 2030. So he's out to like 5 years, and his pressure is consistently very low teens, very consistently on that regimen of Xalatan and Cosop. And so I started slow. I started with those kinds of picking and choosing maybe cases where I felt like these patients are at high risk for complications. Let's try something safer just to see if we get lucky. Right. And then we still can always go back and do something more traditional, more invasive if we need to. And so it's sort of picked up steam from there. And then another situation I started using these sorts of combinations of MIGS is that I get a steady stream of referrals from, I'm in a military hospital, but there's a VA hospital near me, the DC VA. I'm at Walter Reed, and they refer me a lot of patients. And the classic demographic is they're young, like 50-something, African-American. They've already failed a trab quickly. They fail multiple blood needlings with multiple 5FU injections. Then they get an AHMED. the Ahmed fails, they needle the Ahmed, multiply a few injections for the Ahmed, and then finally they get referred to me, and they've got a cataract now. Their pressure's in the mid-20s on Xalatan, Cosapt, Alphagan, and Dimox.
So how does their surgery get covered? Is it because it's a military hospital and they're outside of
there's an
normal
agreement.
insurance?
Typically, VA patients don't have eligibility to have care at Walter Reed
Right.
Unless they're retired military.
Okay.
But we have a working agreement with the VA hospital in DC. And so there's a patient sharing agreement so that if they have cases they want to send to us for surgical management, then they will. And the VA will actually pay Walter Reed for surgical services rendered.
Okay.
So that's the agreement. So I get sort of a steady stream of patients from the VA, and they're kind of all that kind of classic demographic. They have horrible field loss. They're young. They're African American. They failed multiple subconjunctival filtration, more traditional approaches, and they get sent to me with the cataract and pressure in the mid-20s on maximum medical therapy. And I'm sort of asked to, okay, now your turn.
Yeah.
Try something.
Do something with these
do something
train
else.
wrecks.
Is sort of the implication.
Yeah.
And so then I go, okay. It sounds like this patient's eye is telling me it'll laugh at any subconjunctival filtration I try, so let's try something else. And that something else has often been combined MIGS. It could be GAT with ECP along with their phaco, since they have a cataract now, or when CyPass was around, I actually did some combinations with phaco, CyPass, and 2 eye stents, or something along those lines. And so that's kind of how it started building for me. It was a slow burn. But as I started to see successes, which there are some failures too, for sure, but I started to see some successes, and I started to see that it was durable. For those for whom it worked, I have patients coming out to 5 years now, and they still have low pressure, stable fields, low pressures, and it hasn't been great at reducing medication burden, that's for sure. They're on Xalatan, Cosapt, Alphagan before surgery, and afterwards maybe they're on Xalatan and Cosapt or Xalatan and Timolol. But
significantly lower pressure.
Significantly lower pressures, right? So I think in my group of 72, they started with an average of, I think it was 22. I think the standard deviation was like 8 or 9 on about 3.5 medicines. And then at last follow-up, for those who haven't failed and made it to at least post-op month 1 and some out to post-op year 4, the average pressure was about 13. Standard deviation usually hangs out around 3 across all time points, and on about 2.5 meds. So still on a significant medication burden, but
and more important than just pressure values, testing
and
stable.
Stable. And if they're not, then of course they get advanced to more surgery, so they're considered failures. And I think there's so far been 11 failures, at least at the time point that I checked. I'm sure there'll be more in the future, but at least for now, so it's not perfect. It has, but it's a nice other tool to have in the toolbox, as opposed to just repeating the same thing over and over again. So just something that I initially tried to minimize complications, to avoid traditional filtration surgery. Then it turned into, they've already failed everything, let's just try something else.
Now, are these all end-stage patients, or have you moved it up and patients less worse off now are getting multiple combined procedures?
Yeah, most of them are kind of bad off, because I feel like if they're just mild, moderate, I could just do regular MIGS, they'll probably be okay.
Yeah, okay.
But they're usually that setting where they're kind of, the average field loss in my group of 72 is minus 15 decibels. That's the average.
Right, and that leads to another thing in terms of the follow-up for progression. When you get to the minus 15 decibel range, it gets hard to use the visual field for determining progression.
That's true. Yeah, and then probably at that point, OCT is semi-useless too, right? They're kind of at the floor on their. That's true. Yeah, but
I guess with these patients,
from what I can tell, the ones that have succeeded, their fields look stable over. Some have out to 5 years. Right,
and with the advanced damage like that too, you would expect if the patients were getting worse, they would be coming into you saying, things are getting worse.
Right, that's definitely part of every visit.
You have to listen to our patients.
Do you feel like you're okay, or do you feel like you're getting worse? And so it's not perfect. It definitely has disappointed me at many times, just like everything else. But it's just another tool in the toolkit, and I think it's been important for me because. Of those reasons, of dealing with patients, a steady stream of patients who've already failed multiple surgeries by the time they get to me.
Yeah. And one last question, which you've been asked before, which is, when you're doing the multiple procedures,
Yeah.
how do you know which one's working?
Yeah, I don't. And so I know.
Does it matter?
Yeah, I remember I was giving the last example in my talk where it was a little bit of a crazy, admittedly, combination, but I mean, this guy was minus 29 decibels of field loss. He'd already failed 2 subconjunctival filtration surgeries. His pressure was something like 28 to 34 after his AHMED.
Right.
And he's 4.5 months out, so I don't think it's just a hypertensive phase anymore. I think he's just failed. So, and he's on Diamox at his pre-op with Xalatan, Timolol, Simbrinza, and Diamox. He was like 22. So he needed a cataract surgery. So I thought, man, this guy needs a low pressure, and he's like failed everything. I'm just going to pull out all the stops. So, to the audience, I know I heard a few chuckles because it seems so ridiculous. But this guy his other eye is a little bit better, but horrible field loss too. Yeah. I'm just fighting to keep this guy seeing. I'm thinking, man, I want to minimize his risk of having to return to the OR again. He's already had multiple surgeries on his other eye too. So I'm thinking, man, I just want to get the lowest pressure I can. I'm just going to pull out all the stops. Yep. So I guess what I could have done to be more cost effective is I could have done gap procedure on the eye, right? Just to get 360 on the Schlemm's canal. Right. But then I thought, I'm going to spill a bunch of blood into this guy's eye. Let's just stick with implants like Hydrus. So I did micropulse, then I did phaco, then I did Hydrus in the nasal angle. I thought, I'm not going to stop there. I'm going to go to the other side. I'm going to do temporal eye stents through a small nasal paracentesis incision. And then I finished with TCP. And I know it made a lot of people like chuckle, but I was just, I just wanted the lowest pressure I could get for this guy. And with the best odds that he wouldn't have to return to the OR for me to hammer on his eye again. Right. And so that's kind of how, sometimes how the decisions are made. And maybe if I had just done Hydrus and ECP, maybe that could have been good enough, you know? I just... and
the patient's been through enough already. You don't want to
so it's just ideas.
Things.
Let's just pull out all the stops, see if this is good enough. And so at post-op month 1, his pressure was 9 on Xalatan and Simbrinza. So that's better than Xalatan, Timolol, and Simbrinza and Diamox, I suppose. And
how long a follow-up do you have? Yeah, how long a follow-up do you have so far?
Post-op month 1 is the furthest I have for him. He's very recent surgery, but
let's see him in 2 years.
Yeah, that's right.
We'll have to report back.
But I have that small group of patients that have made it out to 3, 4, 5 years, and they still have low pressures. They're still on a lot of meds, but they seem to be stable. So I'm hoping that'll be the result for him too. Yeah. I guess time will tell. But cool. So that's sort of been the concept behind it. Yeah.
Thanks so much for talking today.
Thank you, sir.
Take care. Talking About Glaucoma is a podcast of indeterminate frequency and duration. It's available for free on Apple Podcasts, Spotify, Google Podcasts, PocketCasts, and many other podcast services. Please rate the podcast on Apple Podcasts or your podcast provider and tell your friends about it so that it can reach more listeners. Drop me a line at podcast@igai.org with your show ideas.